After learning about diagnosing and management of chronic stable COPD, now let's go through and learn about management of acute exacerbation of COPD. What do we mean by acute exacerbation of COPD? An exacerbation of COPD is an acute event which is characterized by a worsening of the patient's respiratory symptoms that is beyond normal day-to-day variations, and it leads to a change in medications. The three cardinal symptoms of COPD exacerbations are increase in breathlessness, increase in sputum volume, and increase in sputum purulence. Let's go through a case study. Mr. Manohar, who is a known case of COPD, presents to the clinic with increase in breathlessness since the weather changed 5 days ago. There is no cough or increased sputum. Oxygen saturation is at 96% at room air, and the pulse rate is 96 per minute. He is on regular long-acting tiotropium and ICS plus LABA. So what should be the present advice for this patient? Shall we go with increased using the use of short-acting bronchodilators? Shall we double the dose of tiotropium? Shall we add oral corticosteroids? Or shall we add antibiotics, oral steroids, and the patient needs hospitalization? Well, in this case, it seems like it's a mild exacerbation and it can be managed on outpatient basis. So in this patient, we will advise just adding on inhaled salbutamol with MDI spacer or DPI on an SOS basis, or we can give inhaled ipratropium plus inhaled salbutamol on SOS basis. And then we observe for the improvement in the conditions. If there is no improvement, then we can consider on adding oral steroids for short term. So the same patient comes back in 2 months. This time the patient has complained of increased shortness of breath and cough since 4 days. Patient has expectoration, which is yellowish greenish in color. He also has temperature since 3 days. Saturation is 93% at room air, and patient is not comfortable to perform spirometry. When we auscultated, the patient had wheeze. Now, how we should go about managing this case? Do you think the patient needs admission to the hospital or ICU? Shall we start nebulization? Shall we add injection hydrocortisone or IV minophyllin? Shall we start on oral steroids? Or shall we just add antibiotic for 7 days? So if we have to categorize this patient, this falls in moderately severe exacerbation, and the patient needs additional treatment than just SABA or SABA plus SAMA SOS. Patient has fever and increase in purulence and symptoms, which indicates patient has bacterial infection. Now, infections, whether viral or bacterial, are the commonest cause of exacerbations in COPD. So for this patient, the patient will need antibiotics. So we will, depending upon the suspected strain, we can start on 4th generation quinolones, which has got best bronchial diffusion like moxifloxacin, or we can start on a moxiclav, or we can give clarithromycin. In addition to the antibiotics, the patient will need addition of oral prednisolone. Again, for short term, like 30 mg per day into 5 days. The patient should be started on nebulization, and the nebulizations should be given frequently, like salbutamol or plus ipratropium every 4 to 6 hours. And depending upon the saturation, patient may also need inhaled continuous oxygen. The only important thing that we need to note in this is that we should not nebulize a COPD patient using the oxygen flow. Because if oxygen is administered, it has to be administered separately through a nasal cannula, and it should be at a very low rate of 2 to 3 liters per minute. Because we don't need to increase SpO2s to 99 to 100%, because that will depress your respiratory center, and again it will lead to CO2 retention. So continuing with our case studies, the Mr. Manohar gets increasingly breathless and reaches hospital casualty. The patient now is drowsy, but he responds to verbal commands. Oxygen saturation in the ER is 76%. ABG was done for him, which shows PO2 of 42, PCO2 of 78, pH of 7.18 and bicarbonate of 20. So this is hypercapnia and acidosis. So this ABG is interpreted as respiratory acidosis secondary to hypercapnia. Now what? Now what shall we be doing? Shall we add antibiotics and oral steroids and send the patient home? Shall we hospitalize the patient and start high flow oxygen in ICU? Shall we hospitalize in ICU and start NIV with oxygen? Or we intubate and mechanically ventilate the patient in ICU? Now this is a severe exacerbation and the patient needs care in tertiary care center where there is facility of non-invasive ventilation. However, the patient will need to be stabilized before we are able to refer this patient to the tertiary care. Looking at the indications for hospitalization in such patients, this is if the patient has any of the below criteria like cyanosis, blood pressure, systemic blood pressure is less than 90, respiratory rate is more than 30, heart rate is more than 110, oximetry shows saturation less than 90, patient is having altered sensorium like this patient was drowsy, there is hysterexis, there is presence of severe comorbid conditions like heart failure, arrhythmia, pneumonia, and we have tried our OPD treatment but patient has given poor response to the OPD treatment. There is past history of frequent exacerbation, hospitalization, and there is marked increase in dyspnea. So if this patient has any of these criteria, the patient will need hospitalization. But before we refer this patient to the tertiary care, what shall we do to stabilize the patient? We can start with oxygen therapy, and this treatment should only be done in the centers where oxygen and nebulizations are available. The patients with severe exacerbations should be given low flow oxygen, as we already said, via nasal cannula. We should never give high flow oxygen to COPD patients, which will suppress the respiratory centers. If the facility of saturation monitoring is available, we will administer the supplemental oxygen therapy only if hypoxia is present with target saturation of 92%. Further, what should be done to stabilize this patient is we can start on oral steroid or intravenous steroid, and we can give more frequent nebulized bronchodilators like salbutamol and ipratropium. And antibiotics should be started to this patient. And we should be assessing this patient every 2 hours. So for stabilizing, we have started the patient on oxygen depending upon the SpO2 levels. We have added steroids, or we have given a shot of IV hydrocot or started the patient oral steroids. We have started IV antibiotics, and we have started nebulizing the patient more frequently with short-acting SABA and SAMA. If the patient is still not responding, then prepare to shift the patient to tertiary care center. Patient should be nebulized and given oxygen during the transportation. And at the tertiary care center, the patient may need non-invasive ventilation or mechanical ventilation. Talking a little bit about non-invasive ventilation. Now, NIV is a preferred choice of initial treatment in COPD patient. It is preferred over intubation in COPD patients. NIV has shown better improvement in oxygenation and helps in respiratory failure. It decreases the work of breathing, severity of breathlessness, and also complications like ventilator-associated pneumonia and length of hospital stay. NIV has been associated with less mortality and reduced need for intubation. So, if the patient fits again in the criteria for NIV ventilation, NIV should be the first choice. The patient who fits in the criteria should be started on NIV and then monitored. If the patient improves, then we continue with the NIV. If there is deterioration, like the ABG deteriorates in 4 hours after NIV, then the patient will need mechanical intubation. But if the patient stabilizes with the previous efforts, then what should be our discharge criteria? So before discharging, we should ensure that patient's need for inhaled SABA should not be frequent. So it should come to less than 4 times per day. Patient is ambulatory. Patient can eat and sleep comfortably. Patient's ABG has come back to normal values. The pH is 7.4. PCO2 and PO2 has come to normal values. Patient is clinically stable. And then before discharging, we should educate the patient about the disease, about its treatment, about its complications, so that patient remain more compliant with the treatment and prevent exacerbations in future. Thank you so much.